so we're going to move on to Dr. Pam Keenan. She's the owner of McDonald Hearing Services. So I know that hearing loss runs in my family, right, people? How much of hearing loss is hereditary, and are there also things, really similar to the question I asked Christina, that we can do proactively to stop that progression, even if it runs in our family?
So I think this topic, we need a little bit of clarity because it's kind of a overarching concept talking about hereditary. So there's two different categories. There's congenital and acquired. Congenital is you're born with it. You were born without hearing. So something happened either genetically or in utero to cause the hearing loss. The acquired is something that develops after that. The other thing to differentiate is syndromic versus non-syndromic. So syndromic hearing loss, you have other outlying conditions that are also affected other than the hearing. So there's like Usher's syndrome, Warburg syndrome, neurofibromatosis, things like that. Those are syndromes that you would be actually diagnosed with. The non-syndromic are other conditions that are just maybe a genetic issue. Familial is more than one person in the family having that condition. Sporadic is maybe one person, and it's just one person in the family or a person here or there. So there's a difference between predisposition and heredity. Again, like a lot of other things with the eyes, heart, things like that. If you have a lot of people in your family that have it, you're more than likely than somebody else to potentially have it. It doesn't mean that it's hereditary in the fact that it's a genetic issue. So if it's the sporadic type, which is what most people have, so it's not really genetic. Now, the only way to be proactive about it is there is genetic testing now. So there are ways for these syndromes and the birth issues to be avoided or mitigated by genetic counseling. Other than that, it kind of goes along with what you were saying, good overall health, well-being, blood flow, blood pressure, oxygenation, all of those things can also affect the hearing loss. The number one cause of hearing loss is actually noise exposure. So there are a lot of people in your family that may have hearing loss, but you may be able to connect that directly back to their way of life, a lifestyle, a work environment, things like that. And then, as I mentioned, the comorbidities. So diabetes, because it affects nerves, it can affect the ear as well for the same reasons. That sugar kind of takes over, it's not letting the nutrients through, and eyes, like ears, are highly, highly vasculated. One quick blip of disruption of blood flow can be catastrophic. And then there's ototoxic medications. That's something that you'd want to discuss with your physician. When I say only, there's hundreds of thousands of medications out there. There's about 200 that are actually ototoxic, meaning they will damage your hearing directly as a result of taking them. So you'd want to ask your pharmacist or your physician about that. There's a lot of medications that have a side effect of ringing in the ears but not permanent hearing loss. So you just want to be careful about that. Some of the really common ones are blood pressure medications or Lasix, Bumex. They're the diuretics that can be given. High doses of aspirin can be troublesome. But obviously, do not stop taking anything without consulting your physician, because sometimes they can just reduce the dosage if you're starting to get those symptoms.
That's something I don't think I really would think of. So it's good to hear that. So please take us through what would happen during an initial appointment in your office when someone comes into you for hearing loss. How do you determine if a client is best suited for hearing aids, or if there might be other measures that would help them with their hearing loss?
Absolutely, to reinforce, everybody should get a baseline audiogram. By the time you're 40, 45, because medications that you take, accidents, anything that could happen, you don't have anything to reference back. So it's like a mammogram, vision, everything else. You want to stay up on those and track any progressions and trends to see what's going on. So definitely everybody get an audiogram if you haven't already. The first thing we start with is a questionnaire. So we're going to ask you and potentially a spouse or a loved one how you feel the hearing loss, or if you feel there is hearing loss impacting you. Then we get a really good medical history. So again, we're looking for the ototoxic medications, heredity, diabetes, things like that that could be contributing. Then we're going to do what's called otoscopy. So we have a fiber optic camera. We're going to go down into your ear canal, check the health of the external ear canal and the eardrum. That's all the farther we can see from the outside in. We want to make sure that's all intact. There's no foreign bodies, no wax, anything like that to be managed. If that's all clear, then we move you into a soundproof booth where we do a hearing test. All of this is painless, and it does not really take very long at all. We put you in a booth. You're just going to answer some questions. You're going to push a button when you hear some beeps. We're going to establish where you just hear sound, how you hear in speech and quiet, speech and noise. We're going to go through all of those processes to rule out any underlying medical conditions there may be, and then to determine the type and degree, the diagnosis, or what I call your ear story. Once we're done with that hearing test, we bring you out of the booth, we review that ear story, go through any more questions or concerns, and then we develop a treatment plan. Now that could look different for everybody. It depends on the type and degree of hearing loss and where your difficulties are. Sometimes it's as simple as just referring people to get some earbuds to put in to stream TV. If it's just the TV, that's a problem. If it's something that's more of a serious problem, it may involve hearing aids or amplification of some sort. If not just that, sometimes we have to couple assistive listening devices along with hearing aids. So it depends, again, on what you're trying to accomplish as a goal for better hearing and what your environments are. So it's very, very individual. And that's where the hearing aids that we dispense are a prescriptive hearing aid. So that's going to be something that is tailored exactly to you and your needs.
Makes a big difference versus buying them off the shelf, so to speak.
Yeah,
right?
And just a quick comment about that. Over-the-counter is not the problem. It's when it's applied to the wrong situation. So as long as you read through on those packaging and be sure that you're checking off yes to all of those questions, it may be a start point. They're designed for fairly mild situations, and if you're not somebody who thinks it's an everyday, all-day situation. But I pose the question, how do you know you have a hearing loss? How do you know there's not something in your ear preventing it? How do you know that you don't have an underlying medical condition? So I would definitely strongly encourage people to still come in and get an audiogram, a thorough hearing test by a hearing specialist. Most insurances, if not all, cover it at this point. So as long as you have health insurance of some sort, which most of you all are gonna have Medicare, they do cover. We just need a referral from your primary care, no big deal. But I would definitely encourage that.
Great. So what are some of the typical conditions that would actually warrant a trip to the ENT versus an audiologist? And really also some red flags that people should watch for that would also, alert us to something serious.
Kind of as I was listening to her, kind of similar to the eyes, the most emergent situation would be a sudden onset hearing loss. All of a sudden, boom, you wake up one morning or partway through your day, the hearing goes dramatically down in one or both ears. That is a trip directly to the ER. It's kind of like the medication they can give you when you have a stroke. You have a time window in which they have to give you some sort of a steroid to even potentially reverse this issue. Do not overlook it, do not poo-poo it. It could be just simply wax, but won't you be relieved? You definitely want to get that checked right away. Obviously, any pain, itching, drainage that persists, you want to get in. That could be an urgent care, that could be a primary care visit. That isn't necessarily ER level unless the pain, obviously if somebody's jabbed something into your ear, something obvious like that, you want to get in right away. If you're just wondering and you're not really sure, you could come into an audiologist as well. We can look for any warning signs of what would need to see an ear, nose, and throat specifically. Most ear, nose, and throat doctors have audiologists on staff. They're not doing the testing. So if it's just questioning hearing or gradual changes, we would be your first line of defense. If it's more of a medical issue, potentially, you'd want to get right into them. We, as doctors of audiology, the FDA has warning signs out there. Unfortunately, as a caveat to this, those are no longer enforced because of over-the-counter hearing aids. So there are no red flag requirements of people to report. So it's a visible abnormality of the ear, active drainage in the last 90 days, cerumen or a foreign body, ear pain or discomfort, acute or chronic dizziness, or what I would diagnose as an airborne gap. And then that sudden onset loss. Those are the warning signs we're supposed to be looking for as a provider, and then can get you the referral to the proper location.
I think sometimes, having a professional that can spot something that we would never, spot ourselves. This is kind of off topic, but my mother-in-law actually had colon cancer a number of years ago, and the way that they spotted it was a dental cleaning. She went to a dental cleaning and they noticed that her gums were not looking right. They sent her immediately to the ER. They immediately admitted her for surgery because that was her signal that she had fairly advanced colon cancer. And
yeah, there are a lot of things underlying in the audiogram that we can see too that are heart related and things like that. Another thing you want to watch for is what we call pulsatile tinnitus. That's a ringing or a buzzing or whatever you want to describe the noise in your ear, and it moves with your heartbeat. That is a big warning sign that you may have a carotid artery issue or a blood flow issue. It could be nothing. It's, again, structures are different between people, but that's another one that you would want to get in right away and ask your physician about or mention it.
Great advice. So how about cochlear implants? I know we've heard a lot about those in the last few years. How do they work differently from hearing aids? And what types of patients might be best candidates for implants versus hearing aids? And also a little bit about the cost.
Sure. It's a big topic, and this topic could take itself a whole day. But I'm going to just kind of touch on some of the main bullet points. The cochlear implant is different from a hearing aid in that it is surgically implanted. So once we have determined that your hearing loss cannot be improved with amplification, and there's what we call a 60-60 rule. You have more than a 60 decibel average hearing loss and more than 60% loss of word recognition. That's just the criteria to get tested to see if you are a candidate. There are several categories that they're going to be looking at besides just hearing before they even determine that you are a candidate or not for it. So as audiologists, we know the warning signs. We actually work with cochlear implant patients as well. So once that hearing loss starts to progress to a certain point, we start the conversation because you want to be well informed. This isn't a decision you want to make when your back is to the wall. You want to just be aware. And so it is an electrode that is going to go into the cochlea. So it's going to go into that little snail-shaped object in your ear, and instead of an acoustic and a fluid, it's an electrode, so it's an electrical stimulation to the ear. So it's taking the place of the cochlea, and it's going to send the signal up to your brain where the actual hearing and discrimination happens. So it is different in that case. It is not scary like people think. I mean, it is surgery. You don't take it lightly, but it's outpatient. So those gruesome things and visions that you saw 20 years ago of what this is not it at all. And it can be life-changing. I've had people wait too long, and then, things progress, then you're not healthy enough to do the surgery. Who wants to be absolutely in silence at the best years at the end of their life? So it's definitely something you want to think about. So you'll be determined if you're in the criteria. They'll do a test battery on you to see if you fit all the needs. Then they will send you to meet with an ear, nose, and throat doctor and talk about all the specifics. Because there's a lot of individual differences, and there's a couple of different companies, and there's different reasons why they would go with one versus the other. So they're really the experts in that part of it. But there are local organizations that get together different times of the year where you can just go and you can talk to other people who have been implanted, and surgeons and other care workers that can help you in this process and get factual information. Because again, I feel like there's a lot of misnomers out there about cochlear implants, but it is not something that replaces hearing and replaces hearing aids. It's still highly recommended you go with the best technology you can out there first, and that is part of the requirement to then move on, because they want to be sure that, as sure as they can be, that the cochlear implant will be better than you do with your hearing aids. So you exhaust your efforts with the hearing aids, and again, if you're under the care of an audiologist and we're tracking that hearing loss year to year, we'll start to have that conversation long before it's a necessity, but we'll start introducing that concept to you.
Great. And this final question kind of builds right on that. So there's really been a ton of advances in hearing aids, but I know people who still continue to struggle, especially when they're in different social settings with lots of competing sounds. So are there new technologies or even strategies that can help people with hearing loss really enjoy themselves still in those social situations when there's a lot going on?
Absolutely. Now that's a loaded question too. But just to piggyback back, probably people are wondering, I didn't talk about the cost. Medicare covers cochlear implants. Now, again, you need to meet with your physician. They'll figure it all out. They'll pre-qualify all of it for you. But most of my patients have zero out of pocket for this. So it is something that they, at each of these individual doctor's office, work very hard to figure that out all for you, and you pretty much know down to the penny what it could be expected. So there are other types of ear surgery for for specific types of hearing loss. So if you're determined through the diagnosis that we did that your hearing loss is truly just a medical issue that could be surgically fixed, we refer you out. There's things called bone-anchored hearing aids. There are things called stapendectomies, where they go in and they replace some of the middle ear bones. And that's from otosclerosis. So that's, again, another specific kind of a medical issue that we can detect with the testing. So there's probably about 5% of my patients that actually have some medically correctable type of hearing losses. So new technology could not be any more exciting. I've been an audiologist for 30 years, and I never thought we would be where we are with hearing aids. But again, it circles back to the type and degree of hearing loss and what your word recognition abilities are. And then there's my favorite saying, hearing is a gift, listening is a choice. And you have to be an active listener. You have to be engaged. You can't sit back in the room, close your eyes, and the hearing aids are going to bring everything to you. You have to participate in what unfortunately happens as hearing loss progresses slowly. We withdraw, we pull back slowly. We don't always notice it at first, and by then we've become an inactive listener. Now we've got to reactivate that listening along with the hearing aids. So that's where the hearing aid is an integral part, and we now have fantastic technologies that have directional microphones, noise management, all these things to try to capitalize on the best parts of what's remaining of your hearing. We're using what's left of your hearing to help you hear. We're not regenerating anything, we're not replacing anything. So to take somebody, let's, for example, with a 60% word recognition score and go to 100, is impossibility. So you have to be realistic, and you have to know your type and degree of hearing loss and what's going to happen, and then pick that appropriate technology. And it's very important that you pick the provider versus the technology. And what I mean by that is this is going to be a relationship like your primary care, your dentist. You want to be able to trust them. You want to go in, you want to get good service, and you want a good feeling. So go in, and most places should offer a free consultation just to come in and meet someone, because you want to pick that individual and be confident in their knowledge. We have hearing aid technologies now that do language translation. They'll fall detect. They'll check your blood pressure, your heartbeat. They're going to do blood sugar here very shortly. So anything my Apple Watch does, your hearing aid can do in your ear now. So there are some fantastic things, and there's ways to manipulate the environment with your app on your phone to you pick where the microphones are focusing in that environment. So you have a little bit more control if you want it, or we can make them more automatic. But if you haven't tried hearing aids in the last 2 years, by far, hands down, this year, do it. Just demo them and try it for yourself. They are life-changing. I've never seen the results that we're getting like we do now. Again, it's not perfect, and if you have a trickier hearing loss, we may add other devices along with it. Remote microphones, TV streamers, things like that that can affect that environment. Because if your word recognition is low enough, we can give you a little remote mic, you clip it on. Like right now, I could have it on and I could have patients in the audience. They push the button to their hearing aid and they're gonna hear me like I'm right in their ear with earbuds. You can stream your audio books, your music, all kinds of things. So if you haven't looked at it, go in and at least get a consultation and look into that new technology.
That is so cool. I mean, it really is very encouraging to know that these things are out there and that technology is continuing to get better and better. And as we're talking to these guys, it's just that constant reminder of, doctors of all types, financial planners, lawyers, realtors, all these people in all these different areas, just find one that you know, like, and trust. It just makes sense, that is not gonna, charge you an arm and a leg when you call for a question. These are people that should be supporting you in your journey, whichever category they're in.